So the quest for the ideal insulin continues. We are looking for a longer duration action, more physiological, less risk of hypoglycemia. We will hear from the horse's mouth what's about the newer insulins. Over to you, Doctor.
Thank you for the kind introduction, chairpersons. The younger people in the hall wouldn't have seen that advertisement, but in my college days, there used to be a credit card advertisement which says that there are a lot of things that money can't buy. For everything else, you need this card. That is an advertisement. In the same way, in a diabetic conference, you will listen to talks which says that these are the indications for usage for this drug. Even the previous talk you would have heard, this is the right person for using this drug. This is the place where you can use this thing. This is the combination. But for everything else, you need insulin. And for that purpose, you need to understand the insulin and how it has advanced over the years and how to use the newer insulins and the right place to use it, the right insulin to select, and so that your patient gets a maximum benefit out of it. This is a Novo-sponsored talk, and I hope that they are going to support me financially also. So the insulins, the historical landscape we know, the journey of insulin is more than 100 years. It's actually much more than that. The initial insulin actually was more than a decade before that. But first successful usage and the successful results came around just above 100 years back. That 100 years back, the difference was that people knew that insulin was there, but they were not able to purify it to that level of purity that could produce benefit in a human being without producing significant side effects. That's the reason. Okay, so the insulin journey we know, and the things have come a long way from the animal insulin to the human insulin to the analog insulin. But there are a lot of limitations also. The art of insulins and art of the insulin therapy has not been perfected yet. There is variable absorption, slower onset of action, pronounced peak, the high risk of hypoglycemia, less penetrable and variability, delayed action, no flexibility, rigid dosage schedule, more dosage adjustments, and all sorts of things that are there. So with this background, let me talk about today's agenda, where I'll be talking about maximizing diabetic management with the synergistic power of Ryzodeg, the harnessing Tresiba, a long-acting potential for diabetes management, and enhancing diabetes therapy with FIASP swift action. So we'll be dealing with case scenario. And when I start the first slide of second case, I'll be again asking a question. The previous question was for my generation and older people. And the next question will come to the younger generation. So younger generation, be careful. Okay, so that question will be for you. So the case scenario one is Suresh, who's 54 years, weight 75 kg with a BMI 24, having a normal BP with a medical history of diabetes for 11 years, and the family history, irregular exercise, having a A1C 10.3, which is quite high, and a fasting plasma glucose of 174 and a postprandial of 286. On optimal dose of metformin, glimepiride twice daily, DAPA once daily, and premix already on insulin, premix twice daily, 8 and 10. But the problem is that at that dose of 8 and 10, he complains of frequent hypoglycemic episodes at night and feels lack in quality of life. So what to do? Obviously, we would be talking about insulin, so I should be telling something about insulin only as an answer to it, isn't it? That's a very easy question that I have asked. So the conventional premix, the problem is that the variability in glycemic control, there is incomplete 24-hour basal coverage, needs resuspension, and shouldering effect is also a prominent limitation. So what is co-formulation? It's not a premix, it's a co-formulation. Why? These are two separate entities. It's not a marriage, it is staying together. There is no relation between them. The two are mixed together, but they maintain their independent status inside that vial. That is co-formulation. So here, there is two insulins. One is a ultra-long-acting degludec, which is 70%, and short-acting aspart, which is 30%, which don't behave totally independent of each other, are just there in the vial. That is why they have called it not as a premix or a mix. but a co-formulation. It's a simple insulin regime with fewer side effects and greater flexibility of your dosage, and they have trademarked it as Ryzodeg. There is no need for resuspension, no interaction, retention, and soluble insulin and fasting. It's useful in fasting and PP management because it has a basal component and a postprandial component. So there are numerous studies, n number of studies. Actually, I would say that this is one program of Novo which they have put the maximum effort on almost every permutation and combination that you can think about in a possible diabetic patient who is sitting in front of you. And you say the scenario and they would have a result that they can show from their studies. That's a widely studied molecule. And from those studies, they have come up with a final conclusion that it has an improved efficacy, lower dose requirement, and reduced injection burden. And finally, the most important thing that is important in our practice is safety, improved safety also. So, as you can see from this data, you can see that the A1C before switching from 7.8 came down to 7.10, 7.1, 7.9 came down to 6.9, 10.3 to 8.9. So there was significant improvement in all glycemic parameters we look upon, like A1C, fasting postprandial with Ryzodeg at 3 months and 6 months post switching from older premix regime. It's not that we are starting them on insulin. The best in the market till that time has been compared with the newer one, and you could see the difference. There, I would like to ask one question. Is this insulin more powerful as compared to the previous insulin that it is showing more benefit? Why is that a newer insulin is showing a better benefit as compared to previous insulin? The answer would be the limitation of insulin therapy. What is the most prominent limitation that we face in insulin therapy? We know that there is no upper limit of A1C control reduction that we can attain with insulin. But still, why are we reluctant in reaching to that target level in most patients? It is hypoglycemia, isn't it? So the limiting factor of insulin therapy is hypoglycemia. And when you have hypoglycemia, or when the doctor and the patient gets to the fear of hypoglycemia, then as you reach the target, you feel hesitant. For example, when I myself was practicing in diabetes with NPH insulin, the moment the fasting plasma glucose reaches 900, I would be a bit shivering. Why? I know that the glycemic variability, with the glycemic variability that is there, sometimes the patient may go into hypo, sometimes the patient may be in the hyper. So the glycemic variability coming down, the predictability going up, obviously you become more confident in reducing from that state of fasting plasma glucose of 100 down to 90 and down to 80 with confidence. Why? Because you know that this insulin is much more stable and produces a more stable action profile in your patient, that finally you can reach to a much better target without producing that serious hypoglycemia in your patient. That is the reason why the premix and the newer co-formulation, there is a difference. It's not that this is a more powerful insulin. So that significant improvement is the thing that is reflected in the glycemic parameters when you say that the A1C has come down from 7.8 to 7.1. So the dose reduction of included component is also there, because even with insulin pump, we have seen, when you shift the patient on basal bolus to insulin pump, you see a dose reduction of 20%. Why? Because the glycemic variability that happens comes down, and as that comes down, the stable insulin level that is attained, the requirement of insulin automatically comes down. That's why even in insulin pump, when you shift from basal bolus to insulin pump, there is a reduction of 20%, and that same thing happens here also. There is a dose reduction of 21.43% at 3 months, and at 6 months around 19%. So that means the stability of the glycemic excursion, or the superimposition of this action profile of this insulin to the more physiological insulin profile that the patient requires, reduces the subclinical hypo that happens in this patient and leads to a much lesser insulin requirement. That is the reason. So that's why that. And you also have a much favorable safety profile with less confirmed nocturnal hypo.
Traditionally, we advise mid-morning, evening snack and all that. The patient is on ultra-short drugs, then will it cover that part of the glycemic excursion?
ultra short acting doesn't mean that it is not acting till the next meal. What I would say is that in a normal scenario, most of the patients don't take that mid-morning snacks and mid-evening snacks, and in case that difference would come up mainly in the type 1 diabetic, where the mid-morning snack, this usually covers for it because the duration of action is 4 to 5 hours. So that mid-morning snack and mid-evening snack was predominantly advised because to cover for that shoulder effect. So here we can actually tell them that it may not be actually necessary also. That hypoglycemia risk factor doesn't go, so they can stick on to the 3 major meals. But even if they take a small mid-meal snack, this will cover, that is there. And often we should understand that that is something that has come up as a necessity because of the inherent deficit in the previous insulin that is available. Now with this, you don't have to do that. And in type 2 diabetes, where the insulin is not completely deficient, that mid-morning snack and mid-evening snack, that the pancreas only will take care of when the other things come down.
Very often we have fasting high and all the PPG is also high. Very often. Fasting is also high, post breakfast, post meal, post dinner, all high. Do you have a single solution? I mean, as with all the armamentarium, and other than the basal bolus 3 times, any of the things which...
See, that data I just mentioned, but I don't have it in the slides now. I told you the premix co-formulation, actually they have data which says that it is almost equivalent in efficacy as basal bolus regime. So when the PP fasting both are high and the PPG minus FPG difference is significantly high, then you can go for the co-formulation type twice daily and then increase the dose. Sometimes even the once daily also makes service in a type 2 diabetic based on the A1C level. If the sugar's A1C is quite high, you can go for twice daily itself and then up titrate and you will get a very good result. That's what my personal experience is. Finally, there is no upper limit for insulin dosages.
No, without hypoglycemia.
See, without hypoglycemia is a relative terminology because it is any insulin can produce hypoglycemia. This insulin produces less because it doesn't have that kind of a glycemic variability. So you have to uptitrate. You can uptitrate more confidently to a fasting level of 90 confidently without producing much hypoglycemia. But the moment the patient reaches to that optimal level, if the patient is erratic and all those things, you maybe have to be more careful. See, there is no insulin which will put the hypoglycemia risk at 0%. That is not possible because that is a drug the effect itself is reducing blood sugar, isn't it? So that possibility is not there unless you go for some newer. The science has to improve further, where a dual acting pump or a dual acting insulin has to come, where the glucagon and insulin is together there, which acts like that. So those research has to come up further.
Regarding this reduction in dosage over a period of time happening in co-formulation of Endodiabcon, this we have also been observing. In olden days, whenever this happens, we always think about renal failure when with the conventional insulins or other drugs. Is there any hidden damage of the kidney or any other sphere?
No, sir. Because see, though the company has come up saying that when they shift to the current regime, there is a 20% reduction in thing. But we are people who use insulin pump in type 1 diabetic patients. So we were seeing that since the last 15-18 years, since I started using insulin pumps, we used to see, even in type 1 patients, when you shift the patient from a basal bolus regime to insulin pump, where the glycemic variability comes down and the sugar control comes down, the total insulin dose comes down by 20%. That actually indicates that the patient is getting into better control and the glycemic fluctuation is coming down and subclinical hypoglycemias are tackled, so that the increased appetite that happens with that subclinical hypoglycemia is taken care of, and that's why that is happening. See, it is not a new thing. It is something that is always seen with insulin pump therapy. Now with this new insulin, which is so physiological and so stable, we are seeing that in the insulin regime also, subcu.
I think come out with any algorithm to older premix compared to the present newer insulins?
See, the common sense
You want
is
to
that.
switch over to one from
See, common sense is that if you are switching a patient from the older one to the newer one with a reasonably good A1C control, reduce the dose by 20%. Say you have a A1C of 8 and you want to shift to the newer insulin, reduce the total dosage by 20%, so reduce the overall dosage by 20%. But if you are going for switch in a patient who is having a high A1C with hypoglycemia, you can even start with the same dosage and shift over. Okay, then up titrate further.
I'll ask you one question. How for the rapid acting insulin, would you be comfortable using Tresiba and Fias? Like use Tresiba as a basal.
Yes.
Somebody who's got a very short difference between FPG and PPG, but you're not comfortable using a large dose of Ryzodec there because the aspartate is different.
Yeah, definitely. Tresiba you can use because see, in pregnancy nowadays, one of the commonest regime that we use is Fias with Tresiba. So we almost use that's one area where we need a very strict control, and the guidelines are getting stricter and stricter, and we need to avoid hypoglycemias also. So one of the commonest regime that you use in GDM now is, what I use in GDM now is the combination of Fias with Tresiba.
Because that ready availability is not there. We have to give it separately. Yeah.
We have to give it separately, but when you have to give it separately and you are worried you have to give it as multiple injections, you want that stricter control, then that is the best available option currently.